I can't sleep. I keep seeing the explosion in my dreams and flinch at loud noises. Reported by Mr. Daniel. He presented to the outpatient clinic with symptoms of hypervigilance, nightmares, and intrusive thoughts related to a traumatic explosion incident during his deployment in Afghanistan 2 years ago. He avoids watching news, movies, or discussion related to war and combat. He experiences persistent negative beliefs about himself, detachment from family, and reports difficulty concentrating and irritability. Symptoms have worsened over the first 6 months. Patient's psychiatric history. No prior psychiatric diagnosis, occasional alcohol use, no substance abuse, family history of depression. His father had depression. On mental status examination, patient appeared to be alert but anxious, easily startled, hypervigilant, speech normal in rate and tone, mood is unease, anxious and tense affect, thought process goal directed, thought content intrusive thoughts, trauma, recollections, cognition intact, insight and judgment fear. So, what is the diagnosis? As per DSM-5 criteria, patients suffers from post-traumatic stress disorder, PTSD. The criteria are exposure to actual or threatened death, serious injury, or sexual violence, presence of intrusion symptoms, for example, nightmares, flashbacks, avoidance of trauma related stimuli, negative alterations in cognition and mood, alteration in arousal and reactivity, for example, irritability, hypervigilance, symptoms last greater than 1 month and cause significant distress or impairment. So, this patient is typical case for PTSD. What will be the management approach? It should be combination of pharmacotherapy, psychotherapy, supportive interventions. Definitely monitoring and safety is important. Pharmacotherapy, we can start with sertraline 25 milligram per day, increase to 50 to 100 milligram per day as tolerated. Also need to consider prazosin 1 to 5 milligram at bedtime for nightmares. Psychotherapy should be trauma-focused cognitive behavioral therapy, TFCBT, eye movement desensitization and reprocessing, EMDR as appropriate. Patients should be encouraged and in participation in veteran support groups, educate family members about PTSD and how to support recovery. Regular follow-up for medication titration and side effect monitoring is important. Screen for comorbid depression and suicide risks. Crisis hotline and emergency safety plan in place should be kept. Prognosis is variable but improved with early and consistent treatment. Recovery may take months to years. Continued support is critical. Relapse prevention strategies, continued therapy sessions, medication adherence, stress management techniques, mindfulness, relaxation training, avoidance of triggers when appropriate, and development of coping strategies.